All right, welcome everyone. I'm Harry Kieran, Regional Resource Director in New Jersey for Kieran Treatment Centers. Thank you for joining us for today's webinar entitled Understanding and Treating Failure to Launch Syndrome. As a reminder, we will be conducting this session in webinar format. All participant microphones will be muted. During the presentation, please utilize the Q&A feature to ask any questions you may have. Depending on the volume of questions, if we can't get to your question before the end of the hour, we will have someone from our team follow up with you directly. Today's presentation is eligible for 1 social work continuing education credit. We would like to thank our educational partner, Jumana Grassi, for her assistance in obtaining this credit. Please note that in order to receive your credit, you will need to be on for the full duration of the webinar and complete the post-webinar evaluation. Once you have finished the evaluation, watch for a certificate of completion from Jumana within the next 2 weeks. Today, I am proud to introduce 2 presenters. David Almeida has been a primary therapist at Kieran, Florida for over 10 years, providing individual and group counseling to clients, along with crisis intervention, education, and skills training. He specializes in anger management, as well as both individual and group counseling. Prior to Kieran, David interned and then worked at another treatment center as a primary therapist for 2 years. He is a licensed clinical social worker with a master's degree in social work from Barry University in Florida. Joining David today is our special guest, Dr. Kieran Ayre. Dr. Ayre is the Executive Director of Ayre Counseling, his full-service practice in Morristown, New Jersey. He has spent the last 30 years working with adults, adolescents, couples, parents, and families in a clinical setting. As a preferred provider for executives and professionals seeking mental health or substance abuse services, Dr. Ayre serves his clients in a discreet manner, affording them with the comfort and confidentiality to address their particular concerns. Dr. Ayre is a recognized expert in these areas of co-occurring disorders, treatment, and alternative substance use disorder treatment approaches. In addition to his clinical practice, he is a professor at both Rutgers University School of Social Work and Rutgers University Center of Alcohol Studies. Please help me welcome David and Dr. Ayre.
Right, so my background is that I am a doctoral level social worker. I'm a licensed clinical social worker and a licensed drug and alcohol counselor with 35 years experience working with patients and families with substance abuse and co-occurring disorders. My background really spans 3 simultaneous careers. I've been a clinician for 35 years. Working with individuals and families. I've also been an administrator, a manager, and an owner of various programs, IOPs, rehab, sober houses, and I've been an academic. I've been a lecturer and a professor at a major university. And so I think my background is unique in the sense that I work directly with clients. I am at the cutting edge of the research and the writing in the field, and also understand the business aspect of helping people with those substance abuse and co-occurring disorder. At the moment, I run a boutique practice in Morristown, New Jersey, where we serve clients with individualized and highly specialized approaches toward substance abuse and co-occurring treatment. Kayla, can we have the next slide, please? The topic today is the failure to launch syndrome. And it's something that has been around for quite a while, and it's been discussed in the literature. It's had various different names. Failure to launch is sort of the most current and contemporary way of describing this syndrome, and comes primarily from the 2006 movie Failure to Launch, where Matthew McConaughey and Sarah Jessica Parker played opposite each other. But it's been called a bunch of different things. It's been called Peter Pan syndrome. It's been called the boomerang generation. And even in different cultures in Japan, they call it hikikomori. which is adolescents that grow older, but that they never really kind of leave the home, and they kind of live in the basements or outhouses of their parents' primary residence. So really what we're talking about here when we look at failure to launch is we're talking about a developmental process where an adolescent fails to negotiate and transition from adolescence into adulthood. And so as we all know is that, there are traditional tasks and developmental roles that occur in the transition from adolescence to adulthood. People who suffer from failure to launch syndrome, they fail to assimilate to the tasks and the roles of young adulthood. So as far as incidence is that we see this more so with young men than we do with women. There are obviously cases of young women who suffer from failure to launch, but the most traditional profile is a young man aged 19 to 28 who's struggling with the transition into traditional tasks and roles of adulthood. So when we work with people who suffer from substance use disorder, depending upon where we work and what type of philosophy we have, we use terms like chemical dependency, addiction, alcoholism. And part of the way that we encourage people to make transitions and changes is to encourage them toward the journey of recovery. So similar with failure to launch is that we identify individuals that have these struggles, and we encourage them toward a process of what's called emerging adulthood. So the profile of the clients, as I said, are males, 19 to 28 years old. And there is an increased prevalence in our society. The last piece of statistical research that I saw was in 2016. The researchers identified a 25% increase in cases of young men that were failing to launch. And part of the way that they identified that was that they were saying, and this is obviously pre-COVID, is that 13% of young men aged 19 to 28 were not employed and were not seeking employment. So that's one dimension in terms of what sort of defines the failure to launch profile. But I'll give you some symptoms or some indicators that somebody is in this syndrome. So one thing that we see is that failure to launch, they're unable or unwilling to live on their own. So that in some cases, they will not transition out of the home or can't transition out of the home. In some cases, they will come back. So they go off to college. And for many people, the transition after college is often to independent living after college. And some of these folks, they'll return home and they'll just plant their roots at home, and that there's no effort or movement in terms of an independent lifestyle. And that's why you had this name, kind of the boomerang generation, is that kind of throwing a boomerang. They go out into the world, they go to college, maybe they finish, maybe they don't, and then they end up coming back. People with failure to launch struggle to either get or sustain reasonable employment, or they struggle with the identification of a career path. So these are people who are intelligent, they're resourceful, they have skills and abilities, but they're radically underemployed. Failure to launch also struggle to manage their finances or display any kind of financial responsibility. So they might be working a job that's, let's say, $40,000 or $50,000 a year, but they're living at a lifestyle of $100,000 a year that's oftentimes supplemented or financed by their parents. It's not uncommon to see folks that suffer from failure to launch syndrome that they've either failed out of college or they're on, what we call the 7-year plan, is that, they've gone to 4 colleges over 7 years and they've amassed a total of 15 college credits. And so again, they're failing to to meet the tasks and the responsibilities of this developmental stage. One of the appearances, and I'm going to kind of underscore that word, is that there's an apparent lack of motivation or little intrinsic motivation. So sometimes that's from within the person, sometimes that is from the family constellation or the family structure that sort of promotes that. One of the key characteristics of folks that are in failure to launch is they're passive. They have this incredible passivity. Sometimes it's passive avoidance, sometimes it's passive aggression, and they create dynamics or they lean into dynamics where other people will either complete tasks for them or do much of the work. So an example of that is, I have a 25-year-old client that I'm working with who he's gone to a number of different colleges. He has not graduated from any of them. He's living in his parents' basement. He plays video games all day long and smokes marijuana. And he came in the other day and he said, "Hey, doc, I got an interview for a job at Walgreens, the pharmacy." And I said, "Oh, that's fantastic. I didn't even know you were applying." And he said, "Yeah, actually, my mom filled the application out online for me." So he's like, "You got any clues for me about what I say in my interview?" So that's an example of a failure to launch syndrome, where it's not only the passivity and the lack of action on the patient's part, but the enabling and the dynamic of the parent to complete the task or to set the task in motion. A lot of these failure to launch cases show up in programs like mine and in David's program as substance abuse cases. And so failure to launch cases oftentimes are very prone to escapism, right? And so whether that comes in the form of alcoholism, drug addiction, process addictions like video game compulsion, or other types of avoidant or compulsive behaviors. And so sometimes when patients present to me, with a profile where it's like 25-year-old kid smoking pot every day in the basement, the parent may call and say to me, "Hey, listen, I think my kid's a drug addict or has a chemical dependency. Can you help them?" And so oftentimes after you deal with the initial presenting issue of chemical dependency, what I find is behind that is this whole complicated dynamic and this whole complicated syndrome of failure to launch. The other dynamic here is that failure to launch clients are oftentimes an enormous financial drain on parents and on families. Is that parents oftentimes contribute, or unknowingly sometimes or unwittingly, to the passivity and to the failure to advance by continue to enabling the client. They pay for cell phones, they pay for expensive cars, they have the latest clothes and so forth, and yet the young adult chronologically is not able to kind of participate or accomplish the tasks. So we have people who are frozen and people who are stuck. Is that, they might be in the body of an adult, yet they're very much a child or an adolescent in terms of the way that they interact with the world. So what causes this, right? And I guess the simple answer to it is that I don't think that there's any one singular cause for failure to launch. In most cases, it's a myriad of things. But the first place to sort of begin your rule out is this coming from within the client, or is it outside of the client? Or a third combination, which is the most likely scenario, is that it's a combination or a mix of those things. So things from within the client, right, this is a time period, right, at 19 to 28 years old, where people are growing and changing, and the emergence of psychiatric disorder, major mental health issues, that's a time when it begins to flourish and emerge. And so for some people, the emergence of relatively profound anxiety disorder, social anxiety conditions, depression, other types of serious mental health issues could be a contributing factor to this. This is also a time period where when people begin to make that initial transition out of the home, you have a 19-year-old who goes away to college for the first time, is that some of the things that have traditionally buffered that individual from consequences or from issues in the society begin to emerge in the form of character or personality disturbance. So you begin to see the emergence of a dependent personality disorder or an avoidant personality disorder. There are a whole bunch of other types of underlying causes. I'll just mention them quickly: oppositional defiant disorder, ADD, and ADHD. Which, again, I would caution is that there's a high correlation between people who have failure to launch syndrome and ADD or ADHD. But I would say in my experience is that there's not a causal relationship. People are not in failure to launch syndrome because they have ADD, but it is a complicating factor for a high number. Low self-esteem and substance use or process addictions. So the last part would be so what do we do to help these folks, right? Is that what are the treatment approaches? I think the one thing I would say is that like many mental health and psychiatric issues that we all come in contact with, is that failure to launch happens on a spectrum, right? And so you have acuity and you have chronicity. And so there are some early stage cases that are relatively mild in terms of the acuity. And then there are much more severe cases where it's been going on for a very long period of time and the level of impact on that person's life is profound. So more of the cases that I deal with in comparison with Dave, who's going to speak next, is I might deal with a 19-year-old who has come home after failing out his first year in college, and he sits in a dark bedroom all day watching Netflix and smoking marijuana, and he won't go back to school or can't go back to school. He can't or won't get a job, and his social functioning is rather poor. So that's a more typical kind of case that I might see in my practice. Whereas on the more severe end of the spectrum is that you might have a 30-year-old individual who has been to 4 colleges. They've accumulated virtually no college credit, and they've been in several different rehabs, and that they're driving a $150,000 sports car and basically spend their days at the country club that the family has a membership to. That's a much more severe type of case, and I think that Dave will talk to you a little bit about, his experiences working with folks that are on kind of the further end of the spectrum. But what do we do to try to help these people, right? And I think that the main theme that I would sort of promote to you is that, again, if we think about this from the perspective of a developmental delay or a developmental failure to negotiate the next stage, there's 2 words that I would sort of say would be the backbone of the treatment. One would be promoting perseverance, and the other one would be promoting resiliency. So there's a whole bunch of different ways. Those are the overarching goals, right? And we know as clinicians, there's a whole bunch of different ways in which we try to help people achieve that. But essentially, right, is that when we are children, let's use the example of a traditional developmental process that all of us have negotiated, right? And so I'll use it from a male perspective, is that you're a 16-year-old boy, and you're sitting at the dining room table with your parents, and you look a little bit down, and dad says to you, "Hey, what's up, son?" And the kid says, "Hey, listen, all my friends, they've got girlfriends, and all of my friends have asked girls out, and they got girlfriends, and I don't," right? And so the father says, "Is there a girl you like?" "Oh, yeah, there's a girl I like in my math class, and I'd love to ask her out." So the anxiety and the trepidation, right, the fear of rejection, the anxiety of getting it right, the anxiety of social acceptance for a lot of people is really powerful at that stage. The idea is to help the child navigate that issue, to help them be resilient, to help them foster the strength and the grit to say, hey, go ask the girl out, right? What's the big deal? Some people navigate that naturally very well, and some people never navigate that successfully. And so with failure to launch, that's like an example of something where there's something that's stuck, there's something that's kind of broken. And sometimes that's within the client, and we got to try to help them figure out what that is. And other times it's families who are overly protective, overly indulgent, right? So maybe in the kind of cases that I work with, a parent might say, hey, you know what, there's a young girl that's a friend of a lady that I belong to a lunch club with, and I'm going to ask her if her daughter will go out with you for the first date. So the mom takes away, in that scenario, the mom takes away the anxiety and the opportunity for the person to work that through, right? And with a series of things like that, the patient can develop a sense of passivity and a sense of deflection that, you know, I don't really have to work these things through, right? Is that other people solve these problems for me, or other people will navigate them, or the idea is that the hills are just far, far too high to climb. So there's another aspect of this with the kind of clients that I work with and what David works with, is that not only is there a failure to launch, but with the kind of clients that we work with is that there is this sense of overindulgence. So when you have those two issues that intersect, is that oftentimes what you see is this incredible paralysis, this sense that, you know, people are kind of stuck. They might be in the bodies of a 25, a 28, or a 32-year-old person, but they're really like 13 years old, and they lack the ability to kind of progress with their developmental tasks. So I'm going to kind of pause there. I appreciate your attention and your interest. I'm going to turn it over to David for his part of the presentation.
Okay. All right. Thank you, Dr. Ayre. Good afternoon, everybody. So like Dr. Ayre mentioned, you know, my part is really going to be focusing on some of the more severe cases, and by severe, you know, also meaning the more progressed and also in age. You know, what happens to these patients when they hit 25, 28? It's not like they naturally launch unless there is intervention. And so I actually work mostly now with the population from about 25 to 40 plus. So let me just go into a little bit of a background. I first started hearing about this syndrome in 2010 when I started here at Kieran Renaissance. I remember developing treatment plans for patients early on in my time here. They were titled insufficient autonomy, which was just another kind of fancy way of describing one aspect of failure to launch. I'd say the first half of my time at Renaissance, I worked with the population that Dr. Ayre had talked about, the younger population, failure to launch. The second half is when my caseload started to trend more towards the 25 to 40 population. In preparing for this, I actually went through patients I've worked with over the years, and really the most severe, the clearest cases, I would say, were in that 30 to 40 range. And like I said, this problem only gets worse over time. It doesn't naturally get better. So I'm going to be touching on a few areas, a few symptoms, traits of what I see in my work. So this first slide, again, not surprisingly, we see these symptoms progress over time. I had a patient recently who shared with me that he felt like his parents had basically taken him out to the middle of the ocean and are now leaving him there without learning how to swim. And I think he got the sense that, you know, the gig was up. His family was finally sick and tired of contributing to this. But the reality is he doesn't have the skills or the feeling of competence or adequacy to feel like he's capable. And so I thought this was a really good image to describe this dynamic, that the deeper the patient is in the water, you know, the older they get, the more dependent he or she is on the boat in which they're being taken out into the world on. And again, as they progress, their dependency on family progresses, their interpersonal skills or their lack of interpersonal skills, you know, don't progress. And, you know, they have a difficult time asking for help. They have a difficult time communicating their needs effectively to get their needs met. And as time goes on, there becomes a higher and higher likelihood that by this time there are substance use issues, anxiety issues, depression issues, to the point where, you know, the further on that I see them going, there's a sense of ambivalence and apathy towards launching in the first place. There doesn't seem to be a great desire or motivation to get out of the nest. It's become that comfortable for them. These four areas that I'm going to touch on throughout my talk is the family dependency or codependency issues, life skills and the development of life skills, interpersonal skills, and substance use and mental health issues. The issues with the family, as we all know, become more and more entrenched over time. Interpersonal skills, we see the patients become more and more isolated. As time goes on, relationships tend to be superficial and immature in nature. And the skills needed to develop any type of healthy intimacy are lacking, and that often leads to a feeling of chronic loneliness for a lot of these patients. You know, the development of life skills do not progress as well. This creates more and more shame around the deficits that they do have. And again, I see this population, the older they get, the more difficulty they have asking for help. I had a patient a number of years ago. He was an opiate addict, and he was doing a lot of work around shame that he felt. And as you could imagine, there were a lot of shameful things that he had done that he was trying to work through in his active addiction. And equal to a lot of those experiences he had, when he got to the vocational program, he was in my office really breaking down in tears because he didn't know how to iron his shirt to go on job interviews. And he felt such a feeling of embarrassment that he had to ask somebody to teach him how to iron and what would they think of him. And you know, it was an example that really, to me, highlighted the depth of the shame that these patients have. Over time, they're hyper aware of where they should be and how far behind they are. And that, like Dr. Ayre mentioned, really keeps them in a place where they stay stuck. Substance use and mental health issues, these progress over time. We typically see these patients having been to multiple treatments by the time they come to us. If they're in their 30s, and we see upwards of 10 treatments by this time where they're just in and out, in and out. We can move on to the next slide. Okay. Now, what we also tend to see over time, as all of these symptoms progress with multiple treatments, by now there's likely some legal issues, spotty, inconsistent employment. We see the familial expectation tend to drop over time. What often starts at high expectations, high pressure to excel. The older that these patients get, what we find is that the families really don't expect anything at all. You know, the example on the screen is, you know, I hope my son wakes up on time for work. And you could imagine the questions I get from families of 35-year-olds, 40-year-olds, where they're happy just if I'm reporting back that their child is keeping their room clean or they're making it to group on time. And it's extremely important to work with the family to raise the bar often we tell the families that the patient will, within reason, meet the bar wherever they place it. So if they meet the bar very low, then that's essentially what they're going to expect in return. We could move to the next slide as well. I'm going to go over the case. This is John S. He's a combination, I would say, of a number of this more progressed failure to launch. John's 35-year-old. He's a 35-year-old man. He's from an affluent family system. There wasn't necessarily overt pressure to excel. However, what I would consider more implied pressure based on generational success in business. There's a big sense that image is highly valued in this system. You know, what will people think? And that's both with the patient, that's both with John and the family. Substance use for John begins in high school. And the dynamic where the family really starts to protect the patient from natural consequences begins as well. You know, there's DUIs, the best attorneys they can get to get those charges expunged. An extreme example, which is an actual example, is you know, John got in a car accident under the influence. He called Dad. Dad rushed to the scene. It was a single car accident before the police arrived, and Dad got there and realized there was blood on the airbag. And so what Dad did was actually cut himself with a stick so that when the police arrived, it was feasible that Dad was actually the one who was driving the car, not the patient. And not surprisingly, after this incident, John got access to another car shortly after and actually did get a DUI a couple of weeks later. What this example reinforces in regards to failure to launch is how detrimental an actual or perceived safety net can become with this population. I know Dr. Ayre mentioned, you know, a lacking motivation. You know, John believes that there's no world in which his family is going to let him struggle, let him experience natural consequences, and that does disrupt this necessary, healthy sense of anxiety, urgency to grow up. John, shortly after, goes to college. John fails out of college. He was never forced to develop any type of independent living skills. He moves back home where expectations, again, are pretty low. Family gets him a job, and they wake him up every morning. And as you can imagine, what happens next is he gets fired from the job. He ends up in his first treatment out on the West Coast and relapses a few times, and then actually puts together about 6 or 7 years of sobriety or abstinence. I point this out because even in this period of abstinence, I think a lot, you know, family obviously was very happy that the patient was finally.
I think, did I lose? Can you hear me?
You're fine.
Okay, I'll keep it. So during this period of abstinence, the family, you know, was under the illusion that John was doing well, where in fact, you know, John was out west. He was being supported by family. John was working basically a minimum wage job, which some would consider, you know, a high school summer job, and really not getting up on his own 2 feet. He ended up moving in a girlfriend with the parents' money, and John never truly develops the skills, the competence, the confidence that's important to develop in this necessary phase of launching. In fact, what John reported was feelings of shame increase throughout this time. You know, he would park his $75,000 car down the street from work because he was so embarrassed pulling up to a minimum wage job in a $75,000 car. And he even shared about feelings of jealousy for some of his coworkers who drove around in these clunkers because they earned them, because they were able to buy them on their own. As mentioned, these type of dynamics don't tend to be sustainable. What happened with John is his girlfriend relapsed. John relapsed shortly after, moved back home again, in and out of a number of treatments, and then he showed up to us. The next slide is, so these progressed failure to launch cases, the ultimate goal is we need to sever the cord from the family, but it's not a simple process. And I think early on in my career, I think, it was more of an amputation versus more of a strategical, nuanced approach. We learned that we learned what worked, we learned what didn't work, and going back to the example of not knowing how to swim and being left in the middle of the ocean, oftentimes without this more nuanced approach, we run the risk of the patient just simply sinking, and we don't want to set the patient up for failure in that way. Not only that, what we also realize is that most families, as beaten down and frustrated as some of them become, it's not realistic for them to actually maintain the firm boundaries without having worked on themselves and having obtained support on their own. Otherwise, what we see is the families making these false threats where you're cutting you off if you relapse, you're on your own, and they end up going back on their word. They're not equipped to really be able to hold those lines, and they bluff. And when that happens, it actually reinforces the patient's sense of a safety net. So as I mentioned before, some of the patient barriers that we see include shame, include feelings of inadequacy, lack of interpersonal life skills. Dr. Ayre mentioned this, and I like the image. I have a 15-year-old son, but just to imagine a 13, 14, 15-year-old in the body of a 35-year-old, with 35-year-old expectations and pressures and responsibilities. And, of course, this is going to be someone who is absolutely terrified, who's frozen, who's resistant. And they actually, you see them try their very hardest to stay in the nest. Parental and familial barriers are another area that we need to address. We do find it necessary for parents to be engaged in a parallel process. This means we want them in their own form of therapy, exploring their family of origin dynamics, traumas, any other potential barriers to their ability to maintain healthy boundaries. At times, this is a difficult one, but it's very important that the parents are also going to need to identify possible secondary and tertiary gains to remaining in this unhealthy dynamic. And also working with the family so that they're aligned, whether it's the two parents, whether it's co-parenting, whether it's step parents. We see any fracture or weak link in the system leading to splitting by these patients. Families and parents need their own support system. We often recommend Families Anonymous, Al-Anon. Many families carry similar shame, and they need support from others who can relate to these similar dynamics. The next slide. So let me go into some of our treatment here at Kieran Renaissance and what we found to be effective, specifically with this population. Now, just so that everyone understands, this is basically an inpatient treatment setting. So the patients are already engaged in group therapy, individual therapy. They're meeting with the psychiatrist and addressing any co-occurring disorders that are present. And addressing the family system. And this is, I think someone in the chat asked for a nuanced approach to this, sort of going into that. Every patient and every family that we work with has a primary and a family therapist. So we have a team approach. We have both family and primary therapists assigned to a patient and their family. The families get 2 weekly calls per week, one from the primary therapist, one from the family therapist, both educating the families on this dynamic, oftentimes from different angles. Independent living skills. You know, what we have, the setting we have down here is the patients are living on their own in an apartment style complex. This is about a mile away from the offices. There's 24/7 staff on site that they are sometimes teaching the patients if the patients generally don't have certain life skills like cleaning, like cooking, laundry, holding the patients accountable to keeping up this standard throughout the day, throughout the week. And again, sometimes needing to challenge this population because we do tend to see some resistance to the expectations starting to get higher for them. They're very comfortable with low expectations. Interpersonal skills, this is an area that I'm going to get into a little bit later if I have time around COVID, because it's the area that we've seen the biggest impact in our treatment. It's tough to really practice some of these interpersonal skills when you're in a bubble like we are. But we do typically we have a large alumni and recovery community in the area that we expose our patients to, social situations, interpersonal opportunities to connect on a much deeper level with others who have gone through what they've gone through, going out for coffee, pizza, alumni events, recovery, barbecues. We find that to be very helpful. And then in terms of preparing for post-treatment, we have a career services department, vocational counselors working with each patient in building a resume, interview skills, career assessments if needed. This is often a process that this population has truly never experienced on their own. Now they've used family connections or families have gotten them jobs and taking shortcuts. And what we see is often this is one of the more rewarding parts of the process when they finally do get a job on their own. The pride that you start to see from them is very obvious. And the last part, just briefly, we have a college-bound program. We have a sober dorm on our campus, similar to the career service department. Each patient that's in this track has educational counselors, tutors to work with them on a transition if it is going back to school. The next slide, we're going to go back quickly to our friend John. So not only with John did we work with his family over the phone and over telehealth, we also had them participate in our residential family program. This is where we have a family, usually parents, admit into treatment. They live on our property. They get their own schedule. They get their own treatment plan. Most of the time we do have them living with the patient so that we are able to see the dynamic unfold in real time, and we're able to intervene. This is something I understand is, it's a type of intervention that's not feasible for most therapeutic settings. But I did want to bring it up because I think it does highlight truly the need for a parallel process with both the patient and the family. And we just have the luxury really to be able to do it in-house, which we do find very effective. For life skills, you know, John, who I think probably never cooked a meal other than a frozen pizza up until the time he walked in here at 35. You know, we connected him with someone in the community with culinary experience. He learned how to cook. He cooked for himself. And you start to see these patients as they develop some of these basic skills, start to feel better about what maybe some people would say, what's the big deal? It's a big deal for them. It's a big deal for them to do their own laundry, to you know, cook a meal. We pushed John to go out, get a sponsor, to spend time with alumni. and really challenge him to work on some of those interpersonal skills. Job search, he actually completed his resume. He checked in every morning with the vocational group for his plan for the day, and he presented what fields, what type of employment he thinks would be therapeutically what would be the best fit for him. He did end up obtaining employment on his own. He transitioned to an IOP level of care, and then he ended up moving to a local recovery residence. So there is a step down process. You know, we're not going to launch these patients by canon. You know, it's going to be more of, we're going to try to step them down levels of care so that we could work with them and get them in a place where they're more confident in their abilities. The last slide, this is really addressing COVID. I think we're all aware of how much it's affected mental health issues, substance use issues, behavioral health issues, how it's affected our treatment particularly. We have created a bubble here. And so, you know, for example, we've learned, and I think we've actually bridged the gap with telehealth as much as possible. Every group room, telehealth, group room office has a monitor for telehealth purposes. We had to eliminate some of the in-person work, you know, the family workshop work. Again, another example is we're not taking the patients to the grocery store anymore. We've created an on-campus supermarket in the pool house. This affects their ability to go out and budget for themselves, shop for themselves. Now, again, these are skills that a lot of them have not learned. And then the big one again is the interpersonal skills. How do you promote being social, interpersonal, when there's this focus on social distancing? So, you know, we again are doing our best in terms of technology, the Zoom meetings, phone calls, but as you can imagine, we run into different levels of resistance and effectiveness with that. So, you know, the last one is just the job search, the post-treatment process. You know, the job market is not great, so that's more difficult. You can't go out and pound the pavement anymore. So a lot of that stuff is online. So I know we're out of time here, so I want to end there. Thank you.
Thank you, David and Dr. Ayre. We'll now get into some of the questions that were submitted during the registration process. The first question is really one that David just covered, so I'll present it to Dr. Ayre. How have you seen the pandemic impact the failure to launch population?
Well, I think, you know, somebody asked the question before and I responded to it through the chat. I think, you know, one of the things to sort of keep in mind is that technically for failure to launch is that it should be somebody who has both the capacity and the ability to navigate this developmental process. So I think somebody asked before about somebody that was on the autism spectrum, right? And so if somebody has a condition, whether it's autism or they have a traumatic brain injury or they have some other type of major psychiatric illness that interferes in their ability to successfully navigate these developmental tasks, that's not failure to launch, right? You know, is that failure to launch is for people who would otherwise be capable of achieving these things. And sometimes that issue is something that people need a professional sounding board against. So, you know, sometimes I'll get a referral of, let's say, a 26-year-old kid who's living at home, who is, you know, again, the sort of the dweller in the basement, watching Netflix, playing video games, smoking pot, you know, having beer parties or whatever. And the parent will say to me, like, I'm not sure what's going on. but hey, it's COVID, I guess this is kind of normal, right? And so it's about helping parents understand, like, what are the normal limitations from COVID. And yes, as David said and Harry said, is that, listen, there are limitations, right? There are economic limitations, there are job limitations. But I say to parents is that, hey, listen, I have young people that while it's good, they're out there working. They did get jobs, right? That might not be as bountiful as it was before COVID, or it may be a different kind of job, but there are people who are out there getting work. So I think a lot of what we can do is sort of, give people some normal feedback, right? So some guy's 28 years old and that he's gone to 4 colleges, he's got 10 college credits, he's not working, there's, absolute stagnancy in his life. And he sort of says, hey, like, this is what 28-year-old people do, right? As a professional, appropriately and kindly, you can say, nah, it's really not, right? That there are others who are living life in a different way. And many people who are 28 are doing X, Y, and Z.
Perfect, thank you. The next question I have is, what preventative measures should parents consider as their child begins transitioning into this stage of life? How can we set them up for success?
Do you want me to tackle that one?
Yeah, if you want to go first, then we'll give David a chance.
Okay. I think somebody else in the question, the written questions, kind of asked a similar question. And so there's a good piece of literature by a psychiatrist. His name is Dr. Robert Fisher, and he promotes 6 concepts to a successful launch. And, in his writings, what he kind of says is that many failure to launch cases, there are early warning signs. And so as early as age 13 is that there are certain types of typical tasks and things that young people are going to navigate, right? Whether it be with social issues or with temptations like cigarettes or alcohol or whatever. So he has 6 concepts that he promotes in terms of like trying to help parents, coach parents in terms of like, focus on these things. And again, a lot of it is kind of what we addressed before, is that it's a more detailed script. But again, a lot of it kind of relates to perseverance, fostering a sense of resiliency, and helping somebody with more of what might be typically called executive function in terms of thinking about the next stages of their life, the things that they need to be thinking about to accomplish these tasks.
Perfect, thank you. And David, before you jump in, I just want to add a little bit more to that question since we're running a bit low on time. I want to try to maybe get a 2-for-1 here. So with that in mind, do you have any other specific suggestions around helping teens entering this phase, feel a sense of hope after so much has been taken from them due to this pandemic? Proms, graduation, all the extracurriculars that they're used to.
Yeah, so I mean, I think some of those signs that Dr. Ayre had mentioned that we both touched on, I think early intervention in terms of therapy, in terms of family counseling, I believe that is very helpful, because again, there is such a family component, that contributes to this, and so, to not reinforce this safety net, to build some of that resilience, there might have to be some difficulties that the patients are able to work through on their own, not enabling, not doing things for these adolescents so that they do. And even though they might kick and scream, it's really necessary, because once they do leave the nest, it's important that they are equipped, they are prepared. I think that there is, if you are starting to experience some of these issues, some type of referral to both individual and family counseling would be helpful.
Perfect, thank you. And another question that I just saw come through in the Q&A, I think it's worth clarifying. Is failure to launch unique in high-income families, or unique to high-income families?
I would say not necessarily. That'd be my opinion, is that, I think the literature sort of supports the fact that, again, this is a developmental issue. And so I think income's not a causal factor for it. However, I think that, probably with the clients and the families that I work with, and that David and the other people at Renaissance work with, is that, it's compounded by not just affluence, but, what I would say is overindulgence, right? So there are some affluent families that have very, very, clear values regarding you have to work and you have to earn something, right? So I think that, money in and of itself isn't the cause of this. I think it's when, what I see as a very common dynamic is that I work with a lot of extraordinarily wealthy people who are first generation affluent. And they grew up in families where it was blue collar, or in some cases they grew up poor. And many of these parents sort of say, hey, I knew what it was like to go to school the very first day and see all these kids with new sneakers. And I'm looking down at my feet, and I had a 3-year-old pair of sneakers. And I never want my kids to go through that, right? And so what happens is that because they've made a success of themselves, is that they want to buffer their kids from the pain that they experienced growing up, always looking across the fence and seeing somebody that had something more or something better. And unfortunately, that's a mistake, in my opinion, which is that there is value in wanting things, right? Is that, whether you have money or not, to want things, to sort of, kind of crave for things, it's good. It helps propel us. It helps move us forward. When we have everything that we want and more, right, we become, indolent. We become lazy. We become passive. And so I think some parents miss that as they navigate their own struggles and their own turmoil through, like, growing up poor and then, ending up with a multi-million-dollar business.
Perfect. Thank you very much. Well, unfortunately, we are just about out of time here. So thank you again to David and Dr. Ayre for your informative presentation, and to all of our attendees for joining us today. As a reminder, this presentation is eligible for 1 social work credit. Keep your Zoom window open as we conclude the presentation to access the webinar. Karen will have more great webinar opportunities coming up in February. Our next opportunity is February 12th. We welcome Christopher O'Reilly, Executive Director of Kieran Outpatient Treatment Services, to present on calming the chaos with mindfulness-based stress reduction. This presentation will be eligible for 1 Pennsylvania Certification Board credit. You can register for this workshop and view additional webinar opportunities online at www.karen.org/webinars for more details and to register. In the meantime, please reach out to your local regional resource director at any time for additional information, resources in your area, or questions regarding admissions to any of Karen's programs. Thank you for joining us, and have a great day.